hard work that it takes to become a doctor. I can remember sitting in these same seats as you guys, stressed about boards, practicals, lab work, all of that. And when I sat there, I can remember telling myself that this was a dream of mine. You know, when you're taking a DAT, you dreamt of being at the position that you're in now. So you're living your dream. And even though, you know, these times are stressful, sleepless nights, a lot of coffee, a lot of Red Bull, sometimes missing family functions because you have requirements to do at school. When you go through a process, dental school is a process. And sometimes when you're going through those things, you may feel like you're getting broken down throughout the process. Well, what I realized, like looking back on it, is that you're actually not getting broken down, you're getting built back up. You're turning into a different type of animal, like a different type of beast. You're learning superior hand skills. You're learning how to talk and have patient-doctor dialogues. You're learning building character. You're building ethics. And all of those things are things that you need to be successful once you get out. Dental school is hard, you know, and it's a crazy, crazy ride. But when you look back on it, it's a good one. And I think, just as I have, I'm sure Dr. Connor has, you know, you'll appreciate Meharry. Because when you leave, you will be well trained. And if I could give you any advice, it would be to try to get as much as you can out of your education while you're here. And remember, and it's hard at the time, but try to appreciate the process of what you're going through. And as long as you do that, you'll be good. You'll end up being great clinicians because you're going to be very well trained and you can compete with anybody when you get out of here. That's enough of my little spiel. We'll get into the lecture though. So we're going to talk about what's in your toolbox, exploring silver diamond fluoride, and you'll hear me refer to this as SDF going throughout the lecture, and anterior crowns. And SDF is pretty much, we're going to get into this, but it's pretty much a liquid medium that you can actually use to arrest caries. So I'm just telling you that on the front end, so as we're walking through and building through this, we kind of have an idea of what we're talking about. And then we'll finish up talking about anterior crowns, which is kind of one of the bread and butter things that we do in pediatric dentistry. So to start off, this is my family. My wife was actually my classmate. So many of you guys would have as classmates of us. These are my boys. This is the older picture, like right after Corona had first started. My oldest Carter is the one with all the hair. My youngest Joe, he's 2.5 now. My oldest will be 4 in about 2 or 3 weeks. But this picture is a good example of your classic pediatric patients. Y'all don't know what we went through to take this one picture. All scribing and toys and this and that, just to get this one, just to take a picture. So can you imagine what it's like trying to do an injection, trying to do a crown, trying to do an emo, trying to do an extraction, trying to do a spacing? This picture kind of like sets up exactly like what pediatrics is like. This is just the second picture of them just a little bit older, about a year ago. And you can see the progression as kids get older. Like my oldest, it's a little bit easier to manage some stuff. But you can see my young one is still all loosened up a little bit. So this is my family. My boys would have been mad if I didn't introduce them. So I wanted to make sure you guys got a chance to see a picture of them. So, contents. We're going to talk about the history of silver and SDF. So we can kind of walk through the progression of how SDF was developed. We'll talk about the mechanism of action, how it works, the advantages and disadvantages, and then we'll talk about a technique called the SMART technique, which is a process that's used to restore these lesions after they've been treated with the SDF. And then we'll finish up talking about different type of pediatric anterior crowns, what situations and cases to use them, and then we'll wrap up with the conclusion. So first, Silver's role in history. Greeks and Romans used to use silver vessels to keep water and other liquids fresh. And there's even been reports in history where whenever they would travel on journeys, they would place silver coins into liquid medium, so water, wine, milk, and the silver coins would actually help to decrease antimicrobial levels and to make the liquids last longer. In the early 1800s, silver sutures were used to treat surgical wounds, so surgeons found that whenever they used these sutures, patients would have less infection and decreased inflammation around the surgical sites. Silver leaf was a product that was used to treat wounds in World War I. So soldiers, whenever they were in the trenches and in battle, they got injured, they would use the silver leaf to kind of hold them over to decrease their level of infection and so they could get to the doctor and be treated. In 1891, Dr. Stevens hypothesized that silver was capable of stopping caries causing bacteria. And he found this out by using amalgam scraps and mixing it with silver nitrate and testing it on patients to see that it would actually arrest the caries. In 1908, Dr. G.B. Black, who people call one of the founding fathers of modern dentistry, he used silver nitrate to treat caries in children. And in 1917, Percy Howe treated caries with silver nitrate, and he used it so much that dentists around the area would nickname silver nitrate Howe solution, which was just bottles of silver nitrate. So the inspiration for SDF. There was a process called origoro in Japan that dated back to 1000 AD. Where it was used for cosmetic blackening of the teeth. It was seen in higher society people, aristocrats, where they would darken their teeth as a sign of status. You would also see it in women who were married as a sign of beauty. But what they noticed, and they didn't use silver in this process, they actually used ferrous sulfate, which is an iron, and they mixed it with tannins, but it would darken the teeth. But what they saw in these people was that their caries rate was decreased. And that they didn't get cavities as much as other people in society. As Japan became more westernized in the 1800s, you stopped seeing this practice of darkening the teeth, but that is where it originally started. SDF was actually developed by Professor Yamaga and Professor Nishino at Osaka University in Japan, and what they did was they looked at the antimicrobial properties of silver and also the remineralization properties of fluoride. And they tried to combine these during their PhD studies to come up with a product that would help arrest caries. What they noticed though is that silver and fluoride don't do well together. They have to have an extra medium to keep them compatible. And so they found out that ammonia was actually that third player in everything that was needed to come together to keep silver and fluoride stable. So SDF was approved, and all that happened in the late 60s, 1968, 1969. SDF was actually approved by the Japanese FDA in 1970. So SDF has been used in Japan for almost 60 years now. It was also used in China and Brazil as well, like in the 1980s, but it's just now getting over to America. So the WHO classified SDF as safe in 2009. FDA approved SDF as a device for dentin sensitization in adults in 2014. And in 2015, the first commercial product became available. That's called Advantage Arrest. And that's actually what I use in the clinic. It's by a company called Elevate Oral Care. So that was one of the first, there's only two products on the market. There's Advantage Arrest, and then there's another one called Revastar that we'll talk about in future slides. And FDA was awarded SDF the designation of breakthrough therapy in October 2016. It's the only oral medication that has gotten this designation. And a breakthrough therapy award just means that there is a medicine that meets some currently unmet need in the medical field that is worthy of being used as a breakthrough medicine, even though it hasn't been tested completely. So what is SDF? It's a 38% colorless alkaline topical fluoride solution containing silver ions and fluoride ions. And it's alkaline, so the pH usually sits around 10 to 11 on the pH scale. It's 62% water, which provides a liquid base, 25% silver, which is the antimicrobial portion, 8% ammonia, that keeps everything stable, and then 5% fluoride for remineralization. This is an article by Crystal, Dr. Crystal Yami, and it just talks about the numerous systematic reviews that substantiate SDF's efficacy for caries arrest in primary teeth, and the arrest and prevention of new root caries lesions. It's a great article that kind of covers how to use SDF, when to use SDF, and what it is. It also talks about, and one of the big things with SDF is, so 40% of children, usually before they reach kindergarten, have some type of carious lesion in their mouth. And actually, early childhood caries is the most common chronic disease in America. It's 5 times more prevalent than caries. And early childhood caries just means a child that has caries typically before the age of 5 to 6 years old. And so this article kind of details the overview of how SDF got so popular and why it's used to like treat that circuit of the population. So how does it work? What's the mechanism of action? So we said that silver is the antimicrobial agent that's active against carriogenic bacteria. So we know that's strep mutans, actinomyces N, and lactobacillus, all those bacteria that are caries causing agents. We know that the fluoride helps to remineralize and inhibit demineralization, and it reduces the breakdown of the collagen matrix. 38% SDF inhibits multiple species carriogenic biofilm formation on dentin carious lesions and reduces the demineralization process. This was up from an article by me and et al. In 2013 that found that out. And SDF penetrates enamel at about 25 microns and dentin at about 200 to 300 microns. So this is just a schematic that kind of breaks down the different components of SDF. So just to reiterate where we were with it. So we have the 3 different portions. The silver we know, like we said, is the antimicrobial part. It denatures the bacterial cell wall and inhibits cell division. So these silver ions in SDF, they attach to the bacterial cell wall, they break the cell wall down, then they infiltrate into the bacteria, they shut down pretty much like the respiratory system of the bacteria, which essentially kills it off. And then they bind onto the DNA to inhibit the replication of the DNA. So that's how the silver kills off the bacteria to stop the cavity from forming. And it's also anti-enzymatic. So all those enzymes that cleave and like break down and cause cavities, the silver fights against those to keep them from having enzymatic action. And then it also forms what we call like a silver protein layer. So the silver prevents the bacterial invasion and it improves the dental tubules. And we know that the dental tubules are what communicate from the outside portion in towards the pulp. So the silver, that protein layer that it does, in essence, and we're going to see a slide with that, the silver goes into the dental tubules and occludes them. So that's cutting down on the sensitivity, the communication from the outside in. And that is what ends up arresting the caries, and it actually makes the dentin twice as hard as it was before. Because essentially you have metal mixed in with the dentin. The diamine, like we said, is the ammonia part which stabilizes the solution. The fluoride prevents the demineralization, promotes demineralization. It improves the crystallinity in the men's lattice matrix and the imperfections. And fluoride also is anti-enzymatic as well. And this schematic is from the Journal of Academy of Dental Education. So, how does the silver work? Like we said, it penetrates those tubules, which partially or totally blocks their lumen. And this blockage is what decreases the pain caused by the sensitivity. So the histology you can see on the left is the control. Patient has caries before the SDF was applied on there. You can see how open the matrix is and how open the tubules are. On the right side, you see that area is a lot more hardened. Those tubules are occluded. And that's 12 months after the application of the SDF. Now we'll talk about the blackness that you see on the teeth because that's a part of the SDF. So we're going to get to that in some future slides. This scheme just shows on the left an active carious lesion that has not been treated with SDF. You can see the decay that goes through enamel, goes through the dentin. We see some subsurface caries, and then we see those dentinal tubules leading toward the pulp. On the left side, you see where it's been treated with SDF. That lesion is turned black, which is arrested caries. And then you can see under the subsurface caries and the surface caries where the silver has mixed in with those dental tubules. And the gray that you see kind of right above that red and green portion of the pulp is where that silver has occluded up the tubules. So it makes sense that the sensitivity level would be less because you have that blockage going to the pulp now. So that's why it originally got popular, to help with like root surface exposure, dentin exposure, and things like that. But this is a good little drawing that kind of like puts it all together. So this chart shows the caries arrest by the type of primary tooth using SDF 38% semi-annually, which is twice a year. Lesions with visible plaque and occlusal lesions and large lesions have a less likelihood of arrest. That makes sense. Visible plaque, meaning that hygiene is not too good. Occlusal lesions, we'll talk about that because that's the back surface where you're doing all of your chewing. So they're getting exposed to these caries causing agents a lot more. And research shows that patients with poor oral hygiene benefit from application of SDF at least twice a year. So they found that that is the most effective amount of times to apply SDF. Looking at the chart, you can see that after 30 months, 75% of all teeth treated with SDF had a 75% caries arrest. The lower anterior teeth, and now we're going to look at individual sections. The lower anterior teeth had a 91.7% caries arrest. And that makes sense because we know with the lower anterior teeth, it's constantly bathed with the tongue. It's like a self-flossing system. And anytime you see a pediatric patient that has caries on the lower anterior, you know it's going to be bad everywhere else. Because that is very, very rare to get cavities on the lower anterior on pediatric patients. Same with the upper anterior. It's right there, tongue is near the front, easy to clean, so you would expect caries rate to be lower in the front and higher in the back, because kids typically don't brush as well in the back, and like I said, that's where you're doing all your chewing. So lower posterior teeth, 62.4% caries arrest rate, and upper posterior teeth, 57%. And like I said, this, even though those numbers are lower, that's still a pretty good arrest rate of placing a material on a tooth and being able to stop the decay from forming. Clinical applications for SDF. 1, hypersensitivity. That's what we talked about with the dentin being exposed. 2, help control caries in patients with multiple carious lesions. So these are patients that may have a ton of dental caries in there. Maybe you can only treat one quadrant at that visit, but you're able to place SDF in the other quadrants to buy you some time until you can get that patient back and then finish the remainder of the treatment. To delay the need for sedation. So with sedation, especially like IV sedation, oral sedation, there's certain qualifications that you have to meet in order to sedate a patient. Usually for oral sedation, it's going to be at least 3 years old and 30 pounds. So if we have a 1 or a 2-year-old with baby bottle decay, rotted out front teeth, we need to be able to have something that can delay us until we can get them to the point of where we can actually do a sedation and treat them. Caries arrest for special needs patients. Let's just say we're dealing with a patient who has autism or some type of intellectual delay, and they can't sit through a lengthy procedure. SDF is a way that we can buy us some time or at least arrest the caries so that it doesn't continue to break down the tooth, and then we end up in a situation where there's pulpal involvement or there's fracture of the tooth. You can also use it for incipient and proximal lesions, and we'll show a little schematic of that, of how you do that, but you can stop and try to arrest small incipient lesions interproximally, and recurrent caries at restoration margins. So let's say you've done an MO or a DO on a primary tooth, you see that it has a little recurrent decay around the margin, you can't get to the patient like right then at that time, you can place SDF around the margin, arrest the decay, buys you some time. So it's important to remember, we're not saying that SDF is a definitive treatment. That's not what you want to do and then just stop and don't do anything else. SDF is a minimally invasive dentistry. So you're trying to essentially buy yourself some time because of patient behavior, because of, like I said, some type of a special need. You're trying to get yourself to a point where we can treat these teeth definitively with a crown, with a composite, something like that. Clinical advantages of SDF. Control of pain and infection. The cost is low. 1 bottle of SDF has about 250 drops. And this is the advantage arrest that I'm talking about. 250 drops. You only need 1 drop to treat 5 to 6 teeth. And so essentially that 1 drop equates to about 65 cents per drop. And so you can see it's really cheap and effective. Treatment doesn't require expensive equipment. You can technically do it right here in this room if you needed to. You don't need a dental chair, you don't need dental hand pieces. any of that. It's non-invasive, so we're not doing local anesthesia for it. We're not using a handpiece to drill out anything. And studies show it's safe from fluorosis and silver toxicity. One of the things I forgot to mention too is the product that was used in Japan is called Saccharide. They've sold over 2 million bottles of that, and there hasn't been any reports of any adverse effects from those 2 million bottles. Disadvantages of SDF. It will turn the tooth black. Exactly how you saw in that scheme before is exactly how it shows up on you. So that is the biggest issue with SDF is cosmetically, it is not appealing. But if you're in a situation where you just let the cavity eat away at the tooth, or the patient ends up having pain, or you place SDF and turn the tooth black for a little bit until you can get it restored, you just have to pick your battle on that one. Potassium iodide is actually used in the other product, Rivastar, which is the other type of SDF, which shows to lighten the lesion a little bit. So you can place SDF and then place the potassium iodide over the lesion to kind of lighten it a little bit. But that still is up to debate. A lot of people don't use potassium iodide because we don't know if it affects the bond strength of the composite or the glass ionomer restoration that we put on it. Another disadvantage is it has a metallic taste. So for some patients, once we place it, I usually put fluoride varnish over it. That kind of masks the taste a little bit. It's not a metallic taste forever. It's just a metallic taste like once you put it on there. Or another little trick is you can just put a little toothpaste on their tongue after you place it, and then that kind of helps with mask the taste a little bit as well. It can turn the tissues dark, but that usually dissipates within a few days. So if you accidentally get the SDF on the gingiva, on the lips, on the cheeks, it's gonna stain black. It only lasts, usually it goes away within 2 to 3 days once the skin cells turn over, but it can last up to 2 to 3 weeks. But those are all things that are important to let your patient know beforehand. If you explain everything before, then when something like that happens, it's not a big deal because we already talked about it that this is a potential side effect from it. And like I said before, it's not a definitive treatment. You want to restore with something more definitive in the future. The U.S. Institute of Medicine 6 Quality Aims of Being, they just look at these 6 things to determine how effective a medication is. 1, we know that SDF is safe, so it checks that box off. We know it's effective because we know it arrests caries. It's efficient, it's fast, cheap, and timely. You can do this. You should be able to apply SDF on multiple teeth in less than 5 minutes. It's patient-centered, so you're looking at the values of the patient and trying to focus on what is going to be the biggest help for your patient, and it's equitable. It's a fair treatment. Contraindications. When do you not want to use SDF? Teeth requiring pulp therapy, i.e. the one that you see up there. Teeth presenting with any type of spontaneous pain. So anytime you have pulp involvement, anytime you're having spontaneous pain from a tooth, whether it's root fracture, pulp involvement, these are not the teeth that you want to treat with SDF. It's not going to help in those situations. Individuals at risk for a silver or metal allergy, obviously, you don't want to use that. Patients with open mouth sores, sometimes SDF can kind of irritate the tissues. And parental or patient objection to staining. That is like, if you guys are ever out in the future and you're using SDF, just make sure you let the patient know that the tooth will turn black. And sometimes it's a lighter shade of black, sometimes it's a little gray, but always go with worst case scenario. Just tell them that it's going to turn the blackest black you can think of, and then you'll be fine. And it's good to not only, one of the things that we learned in Meharry is that if you don't document it, then it didn't happen. So you need to make sure in your notes, document that you told the patient everything about the treatment. And also, it would be helpful too to document that you showed the patient some pictures of what the potential outcomes are going to be once you treat this with SDF. These are just 2 of the products that I was telling you about. Rivastar on the right, Advantage Arrest on the left. Rivastar is the one that comes with the potassium iodide to kind of lighten the SDF. Advantage is the one with the 250 drops that I was telling you about that I use in the office. Rivastar is about $100 a box, and maybe a little bit more after coronavirus crisis, but it's 10 vials in there, so you only have 10 applications with that $100. How to apply SDF. First thing you want to do is you want to remove the gross debris from the caries lesion. Sometimes kids will come in for the treatment, they just ate goldfish or some Oreos or something, and it's all caked up on those front teeth. You don't want to apply SDF in the presence of a whole bunch of like food and plaque on the teeth. So even if you just get a toothbrush and do a quick little toothbrush prophy, clean that area off. You want that area to be as clean and dry as possible before application. You also want to make sure you place Vaseline on the tissue surrounding, and that's the lips, the outer cheeks, the gingiva, and you can place it on the teeth that are surrounding that area, even if the non-carious teeth that you're not treating. The teeth that you're treating, you do not want any Vaseline on there because that medium can inhibit the SDF effectiveness. SDF is important to mention that too. SDF does not stain non-carious teeth. It only works on teeth that have caries. You dispense 1 to 2 drops in a disposable dabbing dish. You do not want to use a glass dabbing dish because the SDF reacts with the glass. Disposable dabbing dish, 1 or 2 drops, and you're going to use a micro brush, and you're going to place that right on the caries lesion, being careful to make sure you don't soak it and saturate the brush when you're going over it. You have the potential to drop something on the patient. So you get a drop just enough to moisten the micro brush, and then you apply it. And you want to apply it for at least 1 minute. So you're just constantly just rubbing on the lesions, facial, lingual, wherever the lesion is, for that 1 minute time. And then after that 1 minute, that's all you need for the effectiveness of it. And then you want to remove any excess with either gauze or cotton roll, just something quick to get it all cleaned off. Application time should be a minimum of 1 minute. Then apply the fluoride after the application. You don't have to do the fluoride step. Like I said, I do that to kind of mask the metallic taste, but it also kind of seals in the SDF. And there's no limitations following treatment post-op. They can do whatever they want to do afterwards. So these are just quick examples of how you run through doing it. This is placing the Vaseline on the lips. You can also use, some docs will use like cocoa butter as well. You also want to get it around the lips as well. Like I said, worst case scenario, if it does get on there, that staining does go away, but you can avoid it if you want to. You want to make sure you dry off the lesions as much as you can beforehand, removing all gross debris. And then this is the micro brush. And you're just using it to apply and place it all where the carious lesions are. You just get it all over the tooth pretty much. This is probably about a minute after applying it. You can see it's already starting to turn like a little gray. And typically over a 24-hour period, it's going to get darker. Silver reacts with light as well too, so it'll get darker as those 24 hours go by. But usually after the 24-hour mark, it's as dark as it's going to get. And then this is just me applying like the fluoride varnish on at the end, just to kind of coat it. So, question. This is for anybody. Name 2 clinical advantages of SDF and 1 disadvantage. If anybody can just raise it. Okay, what you got?
Selling off the dental tubule.
One more time?
Selling off the dental tubule.
Okay, that's 1 advantage. What's another one? Same.
Oh, same person.
Yeah.
Arrest the caries.
Okay, arrest the caries. What's the disadvantage?
The staining.
Cool. So we got a gift card. Okay, so SDF and flossing treatment. So this is how you can also, so this is, SDF is not limited to pediatric patients. You can use it for elderly patients as well that have exposed root caries, that have sensitivity. You can use it for adolescent patients and adult patients that have interproximal lesions starting in between. And this is just an example of how you apply that. Same exact steps, except for to go interproximally, you have to use a floss, some people call it a fuzzy floss, but super floss. That is a piece of floss that kind of, you use it a lot for ortho. That has a kind of like a cotton middle piece to it. And once you floss that piece in between, what you can see like on that top left slide, you floss it in between and you just take your micro brush and apply it on the occlusal surface, buccally and lingually around those areas, and that floss soaks up the SDF and it gets it interproximally in between there. Let it sit in there for a minute, and typically you will see those caries arrest. Now, it's important to note interproximal lesions are the hardest ones. They have the lowest success rate. I want to say that the success rate for interproximal lesions is around 40 to 50%, but still, I mean, it's worth a shot. And you can see the good thing with it is aesthetically, if all it's doing is going interproximally, you don't really get, you get the blackening in between the teeth, but On the top surface, if there's no caries there, you're not getting any darkening in it. This is a slide too from Dr. Jeanette McClain. She is like one of the go-to gurus of SDF and the Hall crown technique that Dr. Conner doesn't talk about, but she is really big in pediatric dentistry for these techniques. Reapplication. The application effectiveness has a wide range, 47 to 90%, depending on the size of the lesion, the location of the lesion, and the tooth location. We do know that effectiveness of SDF application decreases over time. Therefore, reapplication may be necessary. So this is just a quick case selection. On the right is a classic type of case that you want to use for it. Maybe a 2-year-old uncooperative, you need to buy time until you can do oral sedation at 3, or until they can get into the OR whenever. Sometimes there's a backbone. Dr. Conner and I were just talking about this. Sometimes you can't get into OR for restoration for almost 8 months sometimes. So you need to kind of buy some time. The case on the left is one of my patients that you do not want to do that on. We have, obviously, you know there's focal involvement if the tooth is all the way down to the gum line. But 2, there's abscesses above E and F up there. So anytime there's active infection, it's cold steel and sunshine for those. They gotta go. So that's not anything that you want to treat with SDF. And then these are just the same things that we went to before, the indications and the contraindications of when you would want to use SDF and when to not use SDF. So next thing we'll talk about real quick is the SMART technique, which is how you restore these lesions after they've been treated with SDF. The SMART technique stands for Silver Modified Atraumatic Restorative Technique. And what that is once you treat the lesion with SDF, you can actually restore the tooth with a glass ionomer or cement. Because SDF does not restore form and function of the tooth. SDF arrests the caries, but if you got a hole in the tooth, you're still gonna have a hole in the tooth afterwards. So you need to restore the form and the function of the tooth so it gets back to doing what it was supposed to do before the caries took over and created an issue for the tooth. And this article just talks about the SMART technique, how it was developed, and also like the different applications for it. So what's the goal of it? You want to halt the decay, you want to seal out any nutrients or bacteria that remain after SDF application, and you want to protect the tooth with the restoration. Why take this route? Sometimes access to patient care may be an issue, or patient access to care could be an issue. Patient population that may have trouble with follow-up appointments. So a lot of the times, like when we go to do these medical mission trips, we may have a patient that needs a crown, but you can't put a crown on it at that time because you don't have access to that. So you treat it with SDF, arrest the caries, and you place a glass iron or cement on there to restore the form and function of the tooth. And hopefully that can buy them some time until they can get, and glass ionomers usually last 2 to 3 years. They're pretty sturdy, they've gotten better over the years. And so hopefully that gives them a little bit of time, wiggle room, so they can get into somewhere and get a definitive restoration. It's non-invasive, it's inexpensive, and it's an effective way to treat caries. Materials. Glass ionomers have been used since the 70s. GIs have improved in aesthetics and wear resistance. And the good properties about GI is its ability to bond chemically to enamel and dentin. You don't have to acid etch. And it has a great marginal seal. Another good thing about GI is that it has a fluoride release and it recharges, so anytime it comes in contact with fluoride, it holds on to it and then slowly releases it as a reservoir. And it has hydrophilicity, so it's okay with being around water. And even when you place GIs, you can actually, when I place it, you can either use your finger. It's not all technique sensitive like if you're doing an amalgam or a composite. You can use your finger, or you can actually use a wet cotton tip applicator, but glass ionomers love moisture. So I usually use a little Q-tip wet, and I just kind of compress it into the area after I've treated the tooth with SDF. And then this is just showing the applicator guns for how you use it. Benefits of the SMART technique: it arrests caries, restores the tooth form and function, also helps to mask the black stain from SDF, providing better aesthetics. And you can place it immediately after you place SDF, or you can do it after the second round of SDF and then place it then. So you don't have to wait. You can do SDF. If the patient's doing well, go ahead and throw the glass ionomer in there and you're good. It doesn't require any prepping, no caries removal or anything. This is just a case study from Dentistry Today that kind of shows that. You can see a distal lesion on tooth number K. This is just a clinical intraoral photo of that same lesion. And you can see the lesion restored at the end with SDF and glass ionomer. And like I said, the good thing with the GI is it actually kind of masks the color a little bit. It's not going to look perfect and exact, but it's a minimally invasive way to treat these carious lesions. Same thing with the bottom. Same exact example. SDF placed, glass ionomer cement placed in there as well. Like I said, you're not removing caries at this point. Now, once SDF is treated on the tooth and it arrests the caries and it fills up the dental tubule with silver, you actually can go in there and prep the tooth and not have to use anesthesia because that caries is arrested and those dental tubules are sealed up with the silver. So you can actually prep the tooth a little bit. Now, obviously, if you're going to be involved in gingiva, then you're going to need some numbing because you're going to feel that. But if you're just removing the arrested decay that you have in there, some docs actually will prep that area out and you don't have to use any anesthesia. And so that's another benefit of why they'll use, and that's even an proximal lesion, that's an occlusal lesion, facial lesion, it doesn't matter. Like if it's arrested, you typically can go in there with a slow speed burr and just kind of remove that little area out of there, at least some of it, and then place the GI. Another case study from Dentistry Today, just showing an occlusal lesion. Lesion before, after application, turns dark, place fluoride, so that means they came back for a second treatment, place SDF the second treatment, and then put the GI on the end. Possible disadvantages. So SDF appears to be compatible with glass ionomer, but its effect on the bond strength of composite to treated dentin is still under study. So SDF is a relatively new thing in the US. It just got approved pretty much in 2016 for like caries arrest. So this is why there needs to be more treatment done. Long-term clinical studies are required to recommend solid treatment protocols. So next we're going to jump in to pediatric crown options. What options do you have to restore decay on the anterior teeth of a pediatric patient that involve multiple surfaces or that extend gingiva? So you can always do a composite, a class 3 restoration. You can do resin crowns, you can do pre-veneered stainless steel crowns, or you can do zirconia crowns. Zirconia crowns are the newest thing on the market for pediatric patients. Before it was mainly just composite restorations, resin crowns, or what we call like a new smile pre-veneered crown, which has a porcelain facing and a metal backing to it. Strip crowns, resin crowns. Advantages, they're aesthetic. You can put whatever color composite you want to in them. And those crown forms that you see, you can match up the shape of the tooth, and then all you're doing is pretty much etch, bond, placing your composite in there after you prep the tooth. And we're not going to get into like how to prep these different teeth because they all are prepped differently, and that would be a whole 2-3 day lecture on how to like prep these different teeth. But they're aesthetic in appearance because you can choose whatever composite you want. You don't have to do as much tooth reduction for them. Pretty much just reducing the incisal and your mesial distals, and then picking your composite and then placing it on there. It's cost effective. The resin crowns are pretty cheap. It's just the cost of composite and the crown forms. So this is a case where you can see decay on pretty much all surfaces of the front 4 teeth, D through G. And then this is restored at the end with resin crowns. They have a great aesthetic appearance. One of the things that you can kind of see on that bottom left photo is if you look really close at tooth E, which is that central incisor on the right, you can kind of see the tooth through the resin crown. That's one of the disadvantages of resin crowns sometimes, is that composite, sometimes you may see a little bit of the natural tooth showing through the composite depending on how much you prepped off. Disadvantages of resin strip crowns is that they're technique sensitive. It has to be super dry. You cannot get composite wet, you know that. And then also if the patient has a lot of like bleeding, inflammation around the gums, resin crowns may not be your go-to because it's going to be a nightmare to try to restore those. And sometimes if you treat the tooth with a pulpectomy or pulpotomy, it can kind of show through the resin because that area may start to turn a little like grayish after time. And they have low durability. So patients who are ruptures, they grind a lot. And then kids in general, they're rough. They got pencils and pens in their mouth, toys, they're playing around, fighting all the time. You can chip resin crowns very easily. Porcelain veneered to metal crowns, advantages, good aesthetics, less technique sensitive. So if you have a feel where it's a lot more moisture, a little bit more bleeding, that doesn't matter. You can still cement the crown onto the tooth. It's less time consuming in resin crowns because you don't have to go through that process of etch, bond, picking out the composite, cutting the crown form off once you put it on the tooth. You just prep, find your size, glue it on there with a little glass ionomer cement, and you're good. Disadvantages, The metal surface on the lingual. Some parents don't like the aesthetic appearance of that, even though you can't really see that from a facial, but some parents don't like to have metal in the mouth. The potential from chipping from wear, and you have to remove more tooth structure than you would for a resin crown. Sometimes it can be difficult to place when you have a crowded patient, and you can only crimp or adjust like the lingual surface of them. And sometimes you can get a gray gingival margin when you cement those crowns. There may be like a little gray halo right where the gingival margin is. So this is an example of a case that I did with some pre-veneered metal crowns. So you can see from the front, it actually looks pretty good. You can see sometimes some of that metal showing, like if the patient opens real big, you can see it from the back side. But those front four anteriors, those are NuSmile crowns. Now this is an example of what happens if a patient chips the crowns. You can see obviously it's not really aesthetic at that point. And that is a very common thing. It's not super common, but it does happen. That is something you need to let the patient know in your treatment plan that, hey, this is a possible side effect of having pre-veneered ceramic porcelain crowns on the front that they may chip, and you may see that metal substructure. So that brings us to zirconia crowns, the newest things on the market. Aesthetics, it's made from a ceramic that's 3 times stronger than porcelain. It withstands wear from bruxism and mastication. It withstands chipping. And it's biocompatible, has a really smooth surface, metal free. So this is your go-to if you have a patient or a parent that doesn't want metal, a patient that's a grinder or bruxer, this is your go-to right here. Because they're not gonna chip. You rarely have any issues with chipping or them coming off or anything with zirconia crowns. And they're very aesthetic.
Can I ask a question?
Yes.
Can you go back to that?
Yeah.
What is the patient cost for those 4 crowns?
Okay. So zirconia crowns, that is one of the things. Typically, in practice, a zirconia crown will run you from anywhere from $250 to about $550. So that could be like a $2,300 smile right there in the front with just the zirconias. So some patients that will deter them, and they'll say, hey, you know what, I'd rather go with NuSmile or the resin crown lamp. So zirconias are your most expensive, NuSmiles with the porcelain facing are your second, and then resins are your cheapest. Disadvantages, they're not ideal for crowding cases. They're more expensive, and the friction against the opposing tooth sometimes can cause some roof resorption, and I have seen even from other doctors cases coming in where patients will develop abscesses under those teeth if the occlusion is super high. Now that's one of the good things about kids. It's not like adults. Adults can have a little bit of an issue where the composite is high and they're in the most extreme pain. Kids, you can have a crown that's 2 millimeters, 3 millimeters high, and their bite adjusts to that over time. And it's usually pretty quick within a couple of weeks. Another thing with zirconia is you can't crimp or adjust the crown. So question, another one. Name 3 types of anterior crowns that we discussed and give either an advantage or a disadvantage. You do either one. What's up?
Yeah, so you have your zirconia crowns,
Right.
which can withstand chipping, but they're very expensive.
Cool.
Then you have your resin crowns, which are transparent, but they're also not as durable.
Cool.
And then you have your porcelain crowns, which they're aesthetically pleasing, but they're also evident as well.
There we go. So this is just an example, and I'm gonna try to run through these because I know Dr. Turner has to get to this presentation, so I'm gonna kind of speed it up a little bit. This is an example of kind of what the preps look like. Now with zirconias, another thing with those, think about it. It's made of all ceramic. NuSmiles, metal backing, you can adjust those. So you don't have to prep as much on those because it's a little bit more forgiving. If you need to let the crown out, you crimp it out a little bit on the metal. If you need to tighten it up, you crimp it in. Resin crowns, that's just composite. So it's just however much you want to prep off the tooth, however much composite you need to restore. With zirconias, because it's made of an all ceramic material, you have to make the tooth fit the crown. And it's whatever size that crown is what size you have to make that tooth. So sometimes you have to be a little bit more aggressive on the preps with those. But this is a typical prep of how it looks when you prep those anterior crowns. This is a case that I did in the OR a couple years ago where a kid had these crowns placed I think he was from Utah, from like two or 3 years ago. He had all that shipping. He had other work to do too in the back. He had bombed out tooth number 8. It was like root tips, and some other teeth that we extracted in the back. But we took those old new smiles off. We put some zirconias in. The bleeding is from his extractions in the back. And this was like immediately after I had just submitted, just to make sure that they were all kind of evenly placed. That's that same patient. This is another kid, was a 4-year-old African-American male, had a lot of like, he was on, his mom gave him a lot of like juice at night. And so this is a common thing that you'll see decay on the front anteriors. It's just a clinical picture of it before we started in the OR. And then that was him restored with the zirconia crowns at the end. This is a case that I did in the office under IV sedation. That was just immediately after I had submitted them, just to kind of look and have my assistant take a picture to see like where we were with alignment. But this is another case with zirconia. So you can see zirconias actually look really good. Now, this is a question. So what type of anterior pediatric crown would you treatment plan for this case scenario and why? This is a hard one. I'm going to show you the picture. It's coming up next, but this was one that had stumped me before when I first pretty much started practicing. This is a kid, 4-year-old. She has decay on K9 to K9 on those front anteriors, but she also has super crossbite. So out of the 3 crowns, what option are you choosing for this? And why? Okay, what you got? Perfect. So that is what you want to choose. You use a resin, it's going to break off. It's going to break off. You use this zirconias, they're harder, but that is what you use that type of light. The crazy thing is, I wish I would have gotten an updated picture on her. It actually corrected her crossbite. Because we did some crowns in the back too, it kind of lifted her bite a little bit. And then with the resin, or with the zirconias pressing on the bite, her bite shifted and she actually jumped the bite and corrected. She got a crossbite just from the crowns being placed. Make sure with pediatric patients, you make sure that they're biting correctly. I know it sounds like the easiest thing, and I can't remember if adults do it or not. It's been so long. But when you ask a kid to bite down, and you ask them to bite down normally, they do the craziest bites. They bite like this, and they're like this, and you're like, no, just bite normal. And they're like, so you have to make sure that the bite is right so you can determine what type of crown you want to use. Definitely, like I said, this wasn't a prep lecture or anything, but you need to make sure you take, when you get out, there are plenty of CE courses to take to learn how to like prep these. This was when I was in the zirconia course, learning how to prep for the zirconias, but they're like 2-3 day lectures. They have them like in crazy places, Vegas, Miami, wherever, Houston, and you can learn how to prep these when you get out. You can also do posterior zirconia crowns. I didn't talk about those, but I just wanted you to see that you do have examples. This is the case from Dr. Kroll. But you can use zirconias in the posterior as well too. They're a little bit more technique sensitive in the posterior. It's hard to do posterior zirconia crowns. You have to have experience with those, but those you do have those options for the posterior. So conclusions. Evidence shows that SDF false caries progression. The SMART technique is an effective way to treat caries if access to care is an issue. Multiple treatment options to address anterior decay of the pediatric patient based on the case presentation. It's just for you to have some extra tools in your toolbox. So when you get out, let's say you're practicing in a rural area, you don't want to treat pediatric patients, but at least you can provide them with a service that will arrest the decay until they can get to a pediatric dentist somewhere. And you want to make sure you get informed consent whenever you do anything. So just make sure you detail as much as you can about whatever type of treatment you're going to perform. This is a picture from around like maybe 2010, 2011, so no, it might have been around graduation, so 2012. But from these 2 guys, man, these are actually, when you're in dental school, you don't realize like how great some of your professors are. And these 2 taught me a whole lot. Dr. Davis, now because of him, whenever I'm like straightening up things in my operatory, Dr. Davis said, you gotta make sure you look like an amateur. If your stuff if it's all scattered over the place. My assistants always see me constantly on my tray. I'm organizing stuff so I don't look like it's a disaster. Dr. Davis fussed at me about my bowl being so dirty one day. I never forgot that. And Dr. Tyus, one of the truly like greatest professor, man. I hear him in my head every day. I still remember freshman year. I don't know if he still does our first year. We had to take an exam and he wanted us to have our white coat on. And I forgot mine. And it was about 5 minutes before we took that exam. I had to run from the top floor all the way down to the bookstore to get a coat and come back all the way up there and to take that test. And I thought he was joking. He was going to be like, oh, no, you can take it. No, I had to run down and get that and buy a white coat that I had gotten home. But it taught me, that's the thing I was telling you guys about the process. It seemed at the time that was something that was like, why did you do this? But it taught me that I needed to be prepared. At any time I come in there for a patient, a procedure, anything, make sure you are prepared and you're professional. And when you do that, you're going to be good. So they taught me to be humble, but never satisfied. It's always a constant grind, always a constant learning experience. And this guy right here, Dr. Nelson still talk about money all the time. Being unequivocally perfect. But same with Dr. Nelson. This picture, and it looks all blurry like this, because you gotta remember, this is like 2009, 2010. We didn't have like iPhone Pro, all that stuff. He's one of my favorite professors. He great, amazing guy. Learned a lot from him. And I really appreciate all my professors. These are just some of the ones I found in my camera roll. But I thank you guys for letting me at least talk to you. I'm sorry I had to rush you.